Good morning, everyone. We are CP group from 6C, and today we are going to do a video presentation on Addison disease and Cushing disease in dog. So now I will introduce myself first. My name is Chong Chun Hong with metric number 192849.
My name is Nurul Shahira Ventika Swadinata and my matrix number is 192986.
My name is Ainadia binti Kasikin with matrix number 192987.
My name is Lee Chai Tong with matrix number 192990.
My name is Nur Shalina binti Muhammad Rafai with matrix number 191969.
Okay, so now we will start with the patient segment.
Okay, so the patient name is Lucky, and then it is a canine. It is a mixed breed dog. This patient is 6 years old and it is a spayed female, and the vaccination status is up to date. Okay, so the history for this patient, this patient vomited 1 week earlier when they returned from the grooming, and then the following week, the patient appetite diminished and seemed thirstier. And for the past 2 days, the patient Lucky become progressively more lethargic and anorexic. So the PE reveals the patient weight of 20 kg. The behavior is responsive but quiet. And the cardiac respiratory status, Lucky has mild bradycardia with a heart rate of 70 beats per minute, pink tachymucous membrane, fair femoral pulse quality but poor metatarsal pulse quality, and unique with normal lung sound. And the body condition is mild prolonged skin turgor with body condition of 2.5 per 5. And then the patient is hypothermia and 5% dehydration.
So in this case, we have come up with several problem lists and also differential diagnosis. For the first problem is 5% dehydration. And the dehydration might be due to underlying metabolic conditions such as ascites, pericardial effusion, and severe metabolic acidosis. It also can be due to gastrointestinal disease such as whipworm infection, acute kidney injury, neoplasia, trauma, and sepsis. So for this problem, we have come up with diagnostic plan, which is complete blood count, serum biochemistry, urinalysis, fecal test, and abdominal ultrasonography. For the second problem is Lucky have poor pulse quality. This might be due to problem number 1. Okay, for the third problem, Lucky has mildly prolonged skin turgor and tachymucous membrane, and this also might be due to problem number 1. For the fourth one is hypothermia. Hypothermia can be due to problem number 1 also, and also can be due to hormonal imbalance such as hypoadrenocorticism and hypothyroidism, and also might be due to kidney disease and heart disease. So for this problem, we plan to do baseline cortisol test and also ACTH stimulation test. For the last one is mild bradycardia. This also might be due to problem number 1 and also problem number 4. So for this problem, we plan to do electrocardiogram to observe sinoventricular rhythm.
Okay, now we will do interpretation.
We have conducted a series of tests. So based on the serum biochemical profile and urinalysis results, we'll talk about some significant findings. So we can see the red blood cell is slightly dropped below the normal range, which indicate mild anemia. And then we can also, in the leukogram, we can see lymphocytosis and eosinophilia. So next, based on the serum biochemistry, the urea, nitrogen, and creatinine are also increased, indicate the azotemia. The glucose is dropped below the normal range, so there's hypoglycemia. And then the calcium also increased, indicate hypercalcemia. Sodium increased, sodium decreased below the normal range, so there's hyponatremia, and potassium increased, indicate hyperkalemia. The urinalysis is quite normal except the specific gravity. So based on the hemogram, we can see the PCB is at low normal level, but the dog is having 5% dehydration, so we suspect the dog might have the anemia masked by dehydration. And then the RBC is slightly lower than normal range, indicate mild anemia, which could be due to the chronic disease. Next, based on the leukogram, we can see eosinophilia and lymphocytosis despite the dog's emergency condition. So this indicates there is lack of stress leukogram, and the lack of stress leukogram may suggest cortisol deficiency in the dog. Next, the serum biochemistry, we can see moderate hyponatremia and marked hyperkalemia. This suggests the aldosterone deficiency that leads to reduced sodium resorption at the collecting ducts, and then also cause the potassium retention in the body. And the sodium to potassium ratio of 16:1 is quite low, which is strongly suggests there is hyperadrenocorticism in Lucky. And the aldosterone deficiency also causes hyponatremia and hypokalemia, because when there's low sodium resorption in collecting ducts, the chloride will also follow the sodium loss. And then glucocorticoid deficiency can cause hypoglycemia. The cortisol deficiency decreases the gluconeogenesis, and then it will also cause the body extremely sensitive to the insulin, so there we can see hypoglycemia. Next, from the exothymia we see in Lucky, we can suggest there is prerenal exothymia or renal exothymia. Prerenal exothymia may be due to dehydration of the dog, and the renal exothymia may be due to many factors that cause failure of renal tubules to function properly, such as the hypercalcemia that decrease the tubule responsiveness to ADH. Also, hypovolemia will lead to hypoxia and reduce renal blood flow and causing renal tubular damage. And all of these factors will cause the renal tubules inability to concentrate the urine properly and finally cause exothymia. The hypercalcemia in Lucky can be due to outer renal excretion, cholecalciferol toxicity, humoral hypercalcemia, or malignancy, or increased calcemia resorption from GIT due to hypoadrenocorticism. So the urinalysis, we can see the SG of 10-18 follow the associated with the dehydration status of Lucky. So it could be isostenuria. So this may be due to medullary washout secondary to excessive sodium loss in the urine or underlying renal disease.
Okay, so based on the ECG result, the reading is showing sinoventricular rhythm with absent P wave and prolonged QRS intervals. This is the typical ECG findings in bradycardic patients due to hyperkalemia. And next one. So for the additional diagnosis, we have done fecal test and also abdominal ultrasound to rule out some differential diagnosis. And based on the blood test result, the presumptive diagnosis is hypoadrenocorticism. So in order to rule out some disease and focus to hypoadrenocorticism, the fecal test is done and the result is negative, and so we can rule out the whipworms. And the abdominal ultrasound, the result also normal, so we can rule out gastrointestinal trauma, ascites, and neoplasia. So for the definitive diagnosis, we have done with baseline cortisol test and ACTH stimulation test. Based on the baseline cortisol test, the result for cortisol level is less than 2 microgram per deciliter, which are consistent with hypoadrenocorticism. And also for the ACTH stimulation test, we need to take 2 blood samples in order to observe the level of cortisol, which is before injection of ACTH and also after the injection of ACTH. So for both result, either in pre-ACTH and also post-ACTH, the result of the cortisol level is showing lower than 2 mcg per deciliter, which is also consistent with hypoadrenocorticism, because in this result we can see that the cortisol level is not responsive to the ACTH injection, so there is no increase in cortisol level, thus the cortisol level is remain low. So for the lack of response to ACTH, it indicates that the animal might have hypoadrenocorticism.
So for the pathophysiology, the hypoadrenocorticism will lead to reduced synthesis of mineralocorticoid, and this will result in alteration of the sodium, potassium, and chloride level. And then it, like in the potassium level, it will cause less potassium excreted by the kidney, which will result in hyperkalemia, which means the potassium level in blood will increase. And then next slide, please, Mark.
Yep.
And then will cause bradycardia, which will lead to hypotension and result in reduced peripheral blood perfusion and will result in prolonged skin turgor. And then for the when there is less sodium and chloride reabsorbed from the renal tubule, this will result in reduced sodium and chloride concentration, which will lead to reduced fluid retention and increased fluid loss, which will cause dehydration. And then for the next one, hypoadrenocorticism will cause reduced synthesis of glucocorticoid, which will result in failure of gluconeogenesis, which will cause hypoglycemia and result in lethargy. That's all.
Moving on to the treatment, according to the problem, electrolyte abnormalities is treated with 50 mg per kg, 10% calcium gluconate bolus, administered slowly over 50 minutes with continuous ECG monitoring. For the second problem, which is dehydration and hypovolemic shock, is corrected with IV bolus of 0.5 gram per kg dextrose, 10 ml of 50% dextrose diluted in 20 ml of 0.9% saline over 2 to 3 minutes to address hypoglycemia. The additional bolus of 400 ml, 20 ml, which is 20 ml per kg of warm lactated ringer solution, was administered over 50 minutes. And the dehydration, which is 5% in Lucky, approximately 200 ml crystalloid fluid administered for 8 hours along with dextrose supplementation to maintain normal glycemia. These are the drugs that are commonly used for the treatment of hypoadrenocorticism, which are cosintropine, dexamethasone or dexamethasone sodium phosphate, prednisone. For mineralocorticoid therapy, we use desoxycorticosterone privilate, fludrocortisone acetate. For gastroprotectant, we use famotidine, pantoprazole, omeprazole, and for antiemetic, we use meropenem. And so far, the prognosis is good since Lucky was discharged the day after presentation. Once she was appropriately hydrated, her electrolyte was corrected, and she was drinking and eating voluntarily.
So in conclusion, the hypoadrenocorticism can cause both aldosterone and cortisol insufficiency. Aldosterone insufficiency will cause hyponatremia, hypokalemia, and hypochloremia, and the deficiency in cortisol can cause hypoglycemia and also absence of stress leukogram. Other findings that we can see including exothymia, isostenuria, hypercalcemia, and also mild anemia.
Okay, this is the reference, and now we will proceed to hyperadrenocorticism. Can you guys see my slide?
Yes.
Yes.
Yeah, now we proceed to patient signalement first.
Shalina on mic.
Okay, so this is an 11 years old dog. The breed is golden retriever. So for the history, okay, so for the past 2 months, the dog, the patient is experiencing PUPD, polyphagia, muscle weakness, abdominal enlargement, endocrine alopecia, and previous diagnostic of hypothyroidism and This patient also received 800 milligram of levothyroxine twice a day without any clinical improvement. So the physical examination, this patient is weighing 43 kilogram, which is overweight, and the body condition score is 3.3/5. The temperament is normal, and this dog has a symmetrical alopecia with abdominal distension.
So in this case, based on the clinical sign, we have come up with problem list and also differential diagnosis and diagnostic plan. So for the clinical sign that the patient have, all the clinical sign is quite specific and lead to the hyperadrenocorticism diagnosis. But beside hyperadrenocorticism, we also come up with other differential diagnosis, which is hypothyroidism and also diabetes mellitus. So for the diagnostic plan, we plan to do complete blood count, serum biochemistry, urinalysis, abdominal ultrasonography, and also low dose dexamethasone suppression test or LDDST to confirm the diagnosis of hyperadrenocorticism.
Okay, so we will proceed to interpretation of hemogram and serum biochemistry. So looking at the hematology, we can see presence of leukocytosis primarily due to increase in neutrophils, indicates neutrophilia. Other than that, increase in band neutrophils above the reference range, but remain below the number of mature neutrophils indicates a regenerative left shift. With the presence of neutrophilia, we can consider inflammatory leukogram, stress leukogram, as well as physiologic leukogram. So physiologic leukogram will be excluded because there is lymphocytosis. Looking at the hemogram, and a left shift is the classic response to inflammation because the sudden demand for neutrophil depletes the storage pool of segmented and band are released. Stress leukogram can also be due to increased endogenous or exogenous corticosteroid in case of hyperadrenocorticism. So we need to do something to differentiate between stress leukogram and inflammatory leukogram. We can do a blood smear to check for any toxic change, which will then, if present, will indicate inflammatory leukogram. Toxic change, for example, can be cytoplasmic basophilia, cytoplasmic occlusion, and presence of Dolly bodies, as well as toxic granulation. So in this case, we can see lymphopenia is a common abnormality in the leukogram of sick animals. The mechanism leading to lymphopenia is seldom differentiated before a final diagnosis is made. So there are many causes can cause lymphopenia, such as corticosteroid-induced redistribution, acute systemic infection, viral infection, immunosuppressive therapy for irradiation, loss of lymphocyte-rich fluid, disruption of lymph node architecture by inflammation, infection, or neoplasia, as well as hereditary immunodeficiency. Other than that, we can also see eosinopenia, which can be occur in response to corticosteroid, catecholamine, as well as in acute infection. The values for monocyte and platelet are still within the normal range. For the serum biochemistry, we can see there is increase in urea concentration, but with normal creatinine concentration, it suggests pre-renal problem, which can be due to dehydration, heart disease, GIT hemorrhage, or other catabolic condition, such as hyperadrenocorticism. There is also mild to moderate increase in ALT and ALP, which are liver enzymes, may occur with hepatocellular injury. Muscle necrosis may also cause increased serum activity of ALT. Increased ALT can also occur with anticoagulant and corticosteroid administration. For ALP activity, it may increase in cholestatic disease, bone lysis or remodeling, corticosteroid treatment or Cushing disease, phenobarbital treatment, as well as hepatic nodular hyperplasia. From the T4 activity, there is mild decrease in concentration in the serum, which can be caused by hypothyroidism, aging, hypoproteinemia, administration of glucocorticoid, in Cushing disease, sulfonamide, phenobarbital, and non-steroidal analgesic. So for low-dose dexamethasone suppression test, we can see after administration dexamethasone, after 4 hours, the cortisol reduced but increased back at 8 hours. So in here, we can make a decision that the pituitary is not responsive to the presence of dexamethasone and continues to produce cortisol. There's no drop in cortisol level is seen at the end of the 8 hours, but small decrease in the 4-hour cortisol level indicates pituitary-dependent hyperadrenocorticism.
Okay, so for next, for the adrenal ultrasonography, there is no evident changes in the adrenal glands. So this aid in the diagnosis of pituitary-dependent hyperadrenocorticism since the adrenal glands is normal. So in order to confirm that, we have done with dynamic magnetic resonance imaging MRI of the brain. So based on the MRI image, we have detected the presence of 6 mm diameter of heterogeneous nodule located on the sella tussica, which was noticed, and that is indicate the pituitary tumor. So with the MRI examination and the LDDST test, we have confirmed that the patient is having pituitary dependent hyperadrenocorticism.
Okay, so for the pathophysiology, it starts with pituitary tumor which cause the excessive production of ACTH, which result in hyperadrenocorticism. Hyperadrenocorticism will cause trisulfogram and the excess production of cortisol. The trisulfogram will show leukocytosis, neutrophilia with slight left shift, and lymphopenia. For the excess production of cortisol, it will result in lipolytic, gluconeogenic, and protein catabolism. This will cause increased liver workload and result in hepatomegaly, which will lead to elevation of ALT and ALP. Okay, so hyperadrenocorticism will also cause increased protein catabolism will also result in muscular weakness and will result in abdominal enlargement. Lipolytic will cause increased fat deposition and also cause abdominal enlargement. And the glycolysis will result in glucose depletion, which will cause hunger and lead to polyphagia. So hyperadrenocorticism will also lead to reduced ADH function and inhibit hair cycle. When the ADH function is reduced, it will result in low water reabsorption, which will cause polyuria and then polydipsia. And then when the hair cycle is inhibited, it will result in atrophy of the hair follicle and lead to alopecia.
Moving on to the treatment options, drugs we can use is mitotin for chemotherapy, 40 to 50 milligram per kg per day, which control hyperadrenostate without causing hypoadrenocorticism. More effective when each dose is ground up, mixed with vegetable oil and administered with food. Decrease to 25 milligram per kg the dosage if the post-ACTH plasma cortisol concentration is less than 55 mol and the dog appears healthy. For ketoconazole, 5 mg per kg BID for 7 days, inhibit adrenal steroidogenesis, increase to 10 mg per kg the dosage BID for 14 days if no problem with appetite and icterus are noted. Perform ACTH stimulation test after 10 to 14 days of therapy at the higher dose while the dog still receiving ketoconazole. Trilostane, 240 mg PO once a day or oral, inhibit cortisol production, mediates the conversion of pregnenolone to progesterone in the adrenal gland, control hyperadrenocorticism in dog for a prolonged period of time, perform ACTH stimulation test 10 to 14 days after treatment and 4 to 6 hours after trilostane administration. Aldepranyl, which administered in a dosage of 1 milligram per kg once daily, inhibit dopamine metabolism, increase hypothalamic and pituitary concentration of dopamine, control hypercortisolism and the associated clinical signs, and increase the dosage to 2 milligram per kg if no response after 2 months.
So in conclusion, diagnosis of Cushing syndrome need to based on patient history, clinical signs, serum biochemistry, and so on. In this case, there is presence of endocrine, alopecia, POPD, abdominal enlargement, and muscle weakness, which is highly suggestive of Cushing syndrome. However, further testing needs to be done to rule in or rule out other problems. In this case, MRI was done to confirm the diagnosis of pituitary-dependent hyperadrenocorticism by showing the presence of pituitary tumor. So now we'll compare Addison and Cushing syndrome. So in terms of clinical sign, if there is presence of endocrine alopecia, abdominal enlargement, muscular weakness is highly indicative of HAC. But then clinical sign or serum biochemistry in Addison disease is not specific. We need to do more diagnostic tests. For leukogram, there may be present stress leukogram due to excess cortisol in Cushing disease. For Addison disease, there will be lack of stress leukogram due to cortisol deficiency. In serum biochemistry for Cushing disease, there will be elevation of liver enzymes, whereas for Addison disease, there is alteration of sodium and potassium level. For urinalysis, both Cushing and Addison disease may show PUPD with diluted urine. Other than that, the effect of Cushing disease on other organ is liver, and for Addison disease, it will affect the kidney. For baseline cortisol test, there will be elevated cortisol in Cushing disease, and in the contrary, Addison disease will have below normal cortisol level. And lastly, for ACTH test, the cortisol level might remain elevated in Cushing disease, whereas for cortisol level in Addison disease, it will below normal even after administration of dexamethasone as test. So these are the reference for Cushing disease, and we have done the presentation. So thank you, everyone.
Okay. Thank you.
Thank you.
Thank you. Bye.
All right,
Stop
bye.
recording, please. Stop.